Good morning, everyone. Welcome to ONC Tech Forum. I'm Avinash Shanbhag, the Acting Executive Director of the Office of Technology here at ONC. I'm honored to welcome all of you to the day 2 of the Tech Forum. We have an exciting day planned for you, so don't go anywhere. Well, if you want to brew a cup of coffee, please go ahead. Before we get started, there are a few folks I wanted to recognize. As you can imagine, pulling a event like this takes a lot of effort, and we have a lot of folks from ONC that have worked tirelessly over the past few months. Particularly, I wanted to call out our ONC team of Mira, Stacy, Lolita, and Cannon, and Jennifer from Kaufman Associates, our event contractor, for working so hard to making sure that all the agenda was set in time and all the speakers were settled to be able to bring this session for you. We had over 1,500 attendees that logged in yesterday. Since all the recordings are available via the platform, in lieu of giving you a formal report out, I'll provide you some interesting statistics. Well, the most viewed track session, as you know, there were 4 tracks that were running concurrently yesterday. Out of the 4 tracks, the most viewed track yesterday was the API Standards and Innovation track with nearly 700 unique views combined over the 2 sessions. Just a little bit of competition for the tracks today. Again, just my anecdotal observation, we had great engagement from folks. There had lots of questions, comments in terms of, and that were really comments that were asked as questions, and lots of activity in our networking sessions and the exhibit booths. So we truly appreciate your engagement and continue, please, to provide that level of engagement to us. We truly enjoy it. Now, I wanted to talk a little bit about some of the work that Office of Technology is doing on your behalf, and again, just give a little bit of window on our activities here. As you can imagine, last year we were busy working with on the cures rule. Now that the rule is out, our team has been busy working to get the certification program launched. And as you all know, as of June 30th, the certification program was officially launched. And we expect and we now, if folks here on especially health IT developers, would be able to join in and take advantage of the program. We will continue to support the program by providing additional resources, answering questions as they come to make that program as effective to the health IT developers as we can. We are also gearing up to support the expansion of the US CDI, the United States Core Data for Interoperability, in the subsequent years. And as you can, and most of you would know, we just recently launched our online submission system for new data elements, the OnDeck system, which will be discussed today in one of the sessions. We look forward to engaging with the community to expand the US CDI in subsequent years. And also, we'll continue to follow the standards advancement activity by working closely with the standards community and also looking at standards to see if they can be put into our interoperability standards advisory, and also potentially to be considered for standards advancement as part of our cures rule. Speaking of standards, we want to also express our appreciation for the many volunteers that work tirelessly across the different standards development organizations to develop these standards. They are very important, and I want to reiterate our continued commitment to support the standards activity through both our staff resources and investment. We also understand the value of state and local HIE infrastructures to support communities in the COVID-19 pandemic. And we hope to have some funding opportunities being announced in the coming days. Please be on the lookout on our websites. Now, a little bit of today's agenda. We have a great lineup of sessions planned for you today. We'll begin with a global panel session where you'll hear from experts from different countries providing insights into the unique challenges and opportunities in the use of health IT in their own countries. After the panel session, we'll have 3 working sessions, not 2, 3 working sessions for the 4 tracks with breaks sprinkled between the sessions. The sessions will cover topics from expanding clinical resources for US CDI to telehealth to monitoring APIs and also ways to leverage population APIs. The exhibit booths will also be open for viewing as the highlighted projects, as also will be the networking lounge for folks to chat with ONC staff and with each other. Finally, a quick reminder, for everyone to finish their online surveys that pop up at the end of each of the session. And if you wish, you may use the survey form to let us know your favorite Steve tip, or send your own tip for having a perfect in-person experience of this virtual event. If we get enough responses, we promise to work with the standards community to get them assigned appropriate control terminologies. Now, a quick announcement before I turn over the panel. ONC will be hosting the next patient identity and matching session, public session, on August 31st. Please be on the lookout for the registration information. And now I will turn over to our national coordinator, Dawn Rucker, to introduce the panel session, Advancing Interoperability Globally. Dawn, take it over.
Yeah, thank you very much, Avinash. For our plenary session this morning, we thought we would talk about really the state of digital health on a more global basis. As we all know, these products, these standards are increasingly international. Certainly for the US audience, many of the standards have actually come from other countries that folks may or may not be aware of. So having a global panel is really, I think, perfect for this. In particular, over the last 3 or 4 years, there's actually been the Global Digital Health Partnership, a program that now includes about roughly 30 state digital health agencies or ministries. So really, these are country-level programs for digital health. Not surprisingly, the world is changing and every country is exploring how to get their patients the benefits of the digital era. So what we're going to do today is have a panel. We're going to start with a video in a minute from Tim Kelsey from Australia. And Tim was actually the person who started the GDHP, I believe. I'm pretty positive. So we look forward to that. But let me just, to give you a flavor, introduce our panelists just before the video, and then we'll have the video, and then we'll get into activities. So let's see, I guess in order of first names, we have Herco Koemans. Herco is the Digital Health Policy Coordinator at the Netherlands Ministry of Health, Welfare and Sports in The Hague. We have Mario Voltolini, who is Chief Technology Officer and Executive Vice President, Product Engineering and Operations at Canada's InfoWay, which is a national digital portal. We have NT Chung. NT is the head of the Information Technology and Health Informatics and Chief Medical Informatics Officer of the Hospital Authority in Hong Kong, and also the consultant for e-health for the Hong Kong government. And finally, we have Dr. Simon Eccles, who graced us in person last year at our tech forum, but in this era of COVID, virtually. And Simon is the Deputy Chief Executive of NHSX, which is the innovation arm of the United Kingdom's National Health Service. And he is also their Chief Clinical Officer for Health and Care. So with that, maybe we can roll the video from Tim Kelsey. Tim is the Senior Vice President of Analytics at HIMSS and has held leadership roles running the Australian Digital Authority and a similar position in England before that. So let's roll the video from Tim.
First of all, thanks to Don and the ONC team for inviting me to join this discussion about the importance of global collaboration in advancing interoperability. Sorry not to be there in person. Time zone, the tyranny of time zones. I'm based in Sydney, where I'm speaking to you from now. So first observation is that healthcare has, in my view, been generally slower than other parts of our lives in harnessing the power of the modern information revolution. And in the background of many health services around the world, the characteristic sound, I think, remains the hum and whir of the fax machine. One GP I know has a 4-foot-high stack of paper in his consulting room that is the record of one patient with a complex history. The evidence, of course, is overwhelming. Paper-based healthcare is inefficient, and it exposes people to very real risk of harm. Where we should see data lakes, instead, we often see health services that seem like dark forests full of tall, disconnected digital trees. I speak to you from Sydney, as I said, and here, in a country which has one of the world's best health services, each year it's estimated that around 250,000 people are avoidably admitted to hospital because of an incident of medication misadventure, almost always because the prescribing physician doesn't have accurate, up-to-date, real-time information on a patient's medicines. Very sadly, more people die in Australia from medication error than from road traffic accidents. The answer, of course, is interoperability. The sharing of clinical information securely, digitally, in real time, so that care professionals and the patients they're caring for have access to the right information in the right place at the right time, and crucially, with commonly understood meaning. Policymakers around the world have no doubt of its importance as a clinical, economic, and above all human priority. In 2018, a group of us, including Don and other colleagues, and at this point I had the privilege of serving as the CEO of the Australian Digital Health Agency, established the Global Digital Health Partnership as a forum for us to share approaches to building interoperability so that we could learn from each other and accelerate our domestic capabilities. Today, more than 30 countries and the World Health Organization are participating in GDHP, and at the recent virtual summit, a set of new white papers were published, including an unprecedented study of global approaches to interoperability, which I know will be a key focus of the discussion today. Don chairs the workstream which produced that report in partnership with 22 countries, probably the richest review of national interoperability policy of its kind, and a very important ongoing resource for policymakers. COVID has accelerated and amplified the critical importance of interoperability. In Australia, like many countries, telehealth and other virtual care services have become the new norm. But governments need to put in place the right long-term standards for data sharing, or there is a risk that current momentum behind digital health will slow and a very positive benefit of this unprecedented crisis be lost. It's not just a matter of future pandemic resilience or of improving the quality, safety and sustainability of health services. The world will not be full of precision medicines if it remains full of fax machines. Thank you.
All right, are we ready to go? All right, so what we're going to do is maybe we'll have each of the speakers tell us just a little bit about what they are, what brought them into health informatics. And maybe Herco, we'll start with you. I have somewhere here also lost my ability to see the rest of the event. So Herco, why don't we start with you, and then you can turn it over to Mario, NT, and Simon. Thanks.
Thank you, Dr. Rucker, and thank you for inviting me again. I was part of the Interoperability Forum last year, and I'm sorry I couldn't bring our famous stroopwafel cookies to this virtual event like we did last year for the whole audience, but I promise we will make that up next time.
Okay, great.
You asked about how I got into health informatics. Well, I'm an urban planner by education, so that's quite a way from health interoperability and health informatics. But I've been a geek and a nerd for quite a while before I went studying. So I tried to combine those two, and that's how I got into electronic government. And from there, from different parts of the government, I ended up at the Ministry of Health, where they wanted me to help design the new governance model for our decentralized health informatics system. So that's how I got into this. Thank you.
Interesting. Mario? Are we getting Mario? Yep. So we'll get Mario on off mute. Okay, maybe while we're sorting out Mario, NT, do you want to give us how you got to the health informatics, and I guess coming from Australia originally, right? I guess we have NT. Huh.
Can you hear me if I'm talking to you?
Yes. I can hear Simon. I can't hear NT. Maybe we'll go with Simon. Simon, do you want to give us how you got into this?
Right. Well, during the light technical difficulties, I tell you what, like everyone else, I'm learning all these different platforms during coronavirus, sometimes using up to 7 platforms in a day. And I think anyone who can make the mute button work each time deserves some sort of medal. I'm sort of Don's opposite number in the UK. And like Don, I was an emergency physician. I still practice occasionally. And realized relatively early on, as Tim was saying so eloquently, that making clinical records ubiquitous was going to make a bigger difference to care than almost anything I could do as a physician. And that was from 2 perspectives. One was the improvement in direct care through being able to see records and previous pathology results and all the stuff that in good organizations we now take for granted. But the other was that we in medicine are forever talking about evidence-based medicine, but basing that on a peer-reviewed journal that's now dealing with data that's 15 years old, rather than running on business intelligence like other industries rely on, that maybe last week's or last month's and is big volumes of data up to date. And it was seeing the ability for that sort of data to make a difference that got me involved. Periodically I try and escape and then find myself back in again.
Okay, great. Thanks, Simon. Yeah, the concept of business intelligence, I think, is really sort of at the heart of modern, deeply digital medicine. Mario, do we have you on now? Let's see. All this worked, of course.
Can you see?
Oh, Mario.
Can you hear me now, Don?
I can hear NT. Why don't we go to NT?
Okay, I got mine sorted out. Yeah, so first of all, Don, congratulations on getting this thing in such difficult times. I'm definitely going to make it to one of your live events one day. So you can hold me to that. Okay, so I started in this field when I was a young fella. I was taken by computers, and this was in the 70s when I first saw a working computer. And I got interested in that, but I proceeded to study medicine. And then I saw how medicine was being run. I mean, it was an entirely manual, paper-based system in those days. And I thought to myself, with my background in dabbling in computers, there's got to be a better way. So I actually was studying medicine, and I was actually developing electronic medical record systems as a full-time job while I was studying medicine. And this was in the 80s. Now, in the 90s, I had the opportunity to move to Hong Kong, where the Hospital Authority, which is where I'm at now, it's a very large provider of care in Hong Kong. And I had the opportunity to come here and become the first informatician ever in Hong Kong. So I took that chance. And basically, they really didn't know what they wanted me to do because there was such a new thing. But I went ahead. Now, I had several advantages coming to Hong Kong. We had no legacy because we were a total greenfield computing-wise. We were able to entirely look at clinical rather than financial and administrative, and that's a huge advantage we've had. It's been very focused on clinical workflow and clinical care delivery, without the issues of dealing with the money side and all that. And the third one is a paradoxical one, which is that we had very little money. We had a low budget, started, but not enough to go and buy something, which meant that we had to develop our own capabilities from scratch. And we've sort of just gone on from there. And that's, I've been here now for getting on to 27 years, building these systems in Hong Kong for the whole of the Hospital Authority.
Yeah, for folks, NT in Hong Kong hosted the GDHP event last year. And I can vouch that the Hong Kong system is absolutely and arguably the best healthcare IT system in the world. It's quite impressive what the fit and finish of what Hong Kong has been able to do. So really a model for all of us. Why don't we, if we can get to Mario.
Can you hear me now? I'll reconnect it and change.
Yes, all right. Excellent.
These are some of the joys of telemedicine and virtual care, right? I would hate to have to explain to my father-in-law, who's 80, how to reconnect to some of this stuff. Anyway, I got, similar to Herco, the way I got into informatics was a roundabout way. I was actually doing a degree in international relations, and one day I was driving along, saw a secretarial school, decided I really needed to learn how to type in order to get my papers completed in an appropriate time frame. And as I went in there, the guy sold me on a computer course instead. And in that course, I actually met two guys who became and still are two of my best friends. And one of their friends actually worked for a software company next door, and they offered me a job, and that's how I got into it. And probably spent the first half of my career in financial services. And then just by happenstance, I had an opportunity to join a healthcare-related project, and I have been doing healthcare now for the past 15 years. And it's complicated here in Canada, and I'm sure we'll get more into the country-specific pieces. But thank you again for having me here today.
Yeah, thanks, Mario. Just for the audience, this platform is really an ambitious attempt to be as close to a actual meeting as we could find. So, the entrepreneurial spirit of trying to not Zoom, different platforms certainly is at work here. Mario, maybe you can talk a bit about Canada's vision with InfoWay and the kinds of things you guys are working on. It's really quite interesting.
Sure. So InfoWay has been around since the early 2000s. InfoWay is actually a not-for-profit corporation that's funded by the federal government. For the largest part of our history, we've played the role of a strategic investor. So we would take funds from the federal government, and we would in turn fund strategic digital health projects across the country and in the different provinces and territories. We've also been managing the standards development or standards maintenance process within InfoWay. At one point, we ran this large group called the Standards Collaborative that actually was the convener for all things related to digital health standards, be they HL7, the terminology side. We're also the publisher of SNOMED CT here in Canada and the licensor for the country, but also being part of IHE, ISO, and so many other acronyms. And then in about 4 years ago, we actually started operating slightly differently. We made the decision that standards were required, but not sufficient. So we took the first steps into actually standing up a system, and we currently operate the National Electronic Prescribing System, similar to SureScripts in the States, except that we, again, are a not-for-profit company. So unlike SureScripts, it's actually owned by plan managers and pharmacy companies. We are completely independent. And it's actually Canada's first cross-country digital health service. And in the process, we're now looking at developing reference implementation of various digital technologies for healthcare. Again, we think that standards are required, but just not sufficient. Actual implementations are necessary to bring people together. And some of the difficulties we have is that, most people talk about the Canadian healthcare system, but we actually have 14 healthcare systems up here. And each province, each territory has its own healthcare system. They vary in size. So the largest province, Ontario, has about 15 million people in its population. The smallest territory, which is Nunavut, has about 35,000 people in it. So the priorities are radically different. The timing of things are radically different. And we try and balance all of these pieces across the country, which definitely makes it interesting.
Great. Urko, do you want to say some of the work you've done in the Netherlands, and maybe also you've been very active in the, working with the European Union and trying to figure out what should be done there. If you want to give us your thoughts, the things you guys are working on.
Yeah, sure. As you know, the Netherlands is only a small country, and it's good to know that we have a publicly funded healthcare system, but it's private delivery. So that means that the government doesn't have a big role in healthcare delivery, and not that many direct levers to push or pull to influence how healthcare providers utilize technology to communicate with each other and with their patients. Our strategy is focusing on basically on getting the right care at the right place, which is now with this pandemic, seems only very logical to see if we can get care outside of hospitals, closer to homes and closer to people where they want to receive this care. And this also means, of course, that we need to have the right data at the right place. And to improve the quality of care, we are focusing as well on giving patients the options to share in the decision-making about their care. It's proven time and time again that if we involve them in the decision-making and give them the data, and more importantly, the information so they can make informed decisions about what type of care they want, then the quality improves and the costs even go down most of the time. Not everywhere, but most of the time they do. As for health interoperability, health IT interoperability, since July 1st this year, a law came into effect. It was written 2 years ago, or finalized 2 years ago, but it was a 2-year grace period that gives patients or citizens the right to a digital structured copy of their medical data. So now anyone in the Netherlands can get a digital version of, a copy of their digital data. This means that the doctor will need to have the data in a digital format, and they are still able to and allowed to send it by a USB stick or something like that. No longer on CD-ROMs, but there's still some options there. And then we thought, what if you as a patient or as a citizen got all your data together? Then what? The data is being protected by our patient-doctor confidentiality laws in every sector, and very, very strictly done as well, and very professionally done as well. We have systems designed to protect the data, but as soon as you have it on your home computer, then it's like the Wild West. So what we wanted to do is provide for a trust platform, and not a government-run platform, but more like a trust framework, which we call MedMe or Medical Me, that providers, personal health data service providers need to certify to, so they can show us that they are using that personal health data in a trusted and safe way. And they provide services like second opinion or care planning, or just regular access and providing information based on the data that's already in the medical files. So that's being rolled out in a controlled rollout, which is a very tightly controlled process, which means that there's now about 30 certified personal health data service providers on the patient end, and about 7 or 8 on the provider end, because that's where they live between those two endpoints. And due to the pandemic, the rollout has slowed down a bit, but the need, of course, has been only become more clear that we do need this kind of an environment and these tools for patients to be able to access their own health data and to report on their health status in a safe and secure way. So that's at the patient end of interoperability. And of course, a large part is also about the provider end. So for the past few years, we've already invested about 100 million euros in our own version of sort of like a meaningful use program, where we call it, we free the data from the silos. So we have financial incentive programs that allow healthcare providers to implement standards and protocols and tools to communicate digitally and structured with each other. Not so much going from paper to digital, because we were already at that stage that we had many digital silos, but now it's breaking through those walls instead of breaking through the paper wall. And the next step, I think, is making digital standardized exchange of health data mandatory by law, by national law. And currently the draft regulation for this is in public consultation. And we do this at a use case by use case basis. So we don't say you have to do everything digital and everything using these standards, but we pick use cases and we say for patient summaries or for e-prescriptions or for other kinds of digital exchange, we make them 100% digital mandatory. So there's no more paper allowed to be exchanged. And they need to be standardized using nationally appointed standards that are, of course, based on international standards as well. So that's what we're working on in interoperability.
That's awesome. Very good. Thank you very much. NT, you guys have built up a pretty impressive infrastructure. Do you want to give people a little sense of that infrastructure and how you did it?
Sure, Don. So just a quick bit of background. So the Hospital Authority is the by far the largest provider of care in Hong Kong. We're a public sector healthcare provider. We have 43 hospitals, 28,000 beds. We basically employ about half of all the medical manpower in Hong Kong and provide care. About 90% of the volume of sort of secondary and inpatient care is provided by our facilities. So we made some early decisions, which I think turned out quite well. So first of all, let me just say this. I'm going to there's two chapters in our interoperability story. So the first chapter happened within the hospital authority, which is the organization I just talked about. So in that chapter, we were building a system for care delivery within the hospital authority. But even so, it's lots and lots of different settings and locations. So the interop still comes into play there. Now, one thing that we decided early on this is that we would have one system across the board. So one system would apply to all of our different hospitals and clinics. And it didn't matter if you were an inpatient setting or an outpatient setting, emergency setting, it'd be the one single system, and you would have one single record. So it's all about the medical record and the clinical data held therein. And so the other decision we made was that record would be a highly structured, a very granular and highly standardized repository. So we would have one patient, one record across the whole continuum, like I said before. So of course, we focused on helping our clinicians deliver better care. So apart from the data itself, we focused on how the workflow and how it interacted with the clinician, how the system interacted with the clinicians as they were doing their clinical work, and how it could actually be helpful rather than a burden to them. So we focused a lot on that those sorts of aspects of care delivery. Now, so what we had by the year 2000, we'd actually had one single sort of electronic patient record for any patient in HA. So no matter which hospital the patient turned up on, their carer could view their entire record and the history as well. So that was already in place 20 years ago. Now, and of course, built on top of that, lots of decision support and all that sort of stuff. And but then the next phase was when the government said, well, we've still got a bunch of private sector hospitals and private sector doctors out there, and they asked us to help them develop the system for the whole of Hong Kong. So that became what we call the EHR sharing system, and that's a government-run system, but government-owned system, but we basically built it and operate it for the government using their experience from the last, the previous 20 years. And that system now basically has, it doesn't have everybody in it because it's an opt-in system, not an opt-out system. At the moment, we have something like 1.4 million patients have been enrolled. And the doctors who are looking at those patients, doesn't matter if they're in private sector or public care, they will still see the entire shared record for that patient. The key to allowing all this sharing across all these different environments is that the data is standardized. Now, we started this quite early, and to be honest, the standards weren't there for what we need to do. So we had to invent a lot of our own standards in the early days. But that's a huge job. And so what we're doing now is we have this sort of a mantra: we adopt, adapt, or invent standards in that order, right? So we'll try to adopt what's available. And I think there's a standards world is doing a lot of great work. The stuff now is getting much more ready for real world. So I think we're trying to go along those lines now. But the sort of thing that we've spent a lot of time on is that how not just the representation of the information in terms of coding schemes and so forth. It's also how data is represented and the sort of the architecture of the information. So one of the things we've done is we've basically said this system has to apply across the board, has to apply to any setting, and has to be able to collect any clinical data, even though we'd never even thought of it before. And that's part of what we managed to build up an architecture that allowed us to just arbitrarily add new clinical information almost on the fly, and to have that act as a first-class data entity within the system itself. So that's sort of the two areas. We've built it for ourselves first within the hospital authority, and then we built it out to the whole of Hong Kong for all the private sector guys as well.
Excellent, thanks. And you've used really basically open source type of tools for this, right? Is that correct?
In fact, increasingly, we have been doing that. I mean, in the early days, the open source wasn't quite as powerful, but now it's really very good stuff. So our entire stack is increasingly open source. We just think it gives us more control, and I mean, the cost is not really the main issue. It's the ability to control it and have access to it no matter what. And we think, but the amount of effort that's going into from the global community is pretty outstanding, actually.
Okay, great. Again, very impressive. Well, let me turn it over to Simon. Simon, the NHS has, shall we say, a storied history in health information technology over the decades. There are many things to say, so I will let you pick the ones of your choice in that long journey.
Always with the giants. And forgive the noises in the background. It's school holidays. My two children are currently in a paddling pool because we're having a heat wave in London. And having just looked at the forecast, we are currently hotter than Washington, D.C. and Hong Kong and the Netherlands and indeed all of Canada. This has never happened before. We're melting because we don't do air conditioning over here. Anyway, I will try and stay upright for the rest of it. You'll be familiar that we have the NHS, a ubiquitous healthcare system, single-payer system across the whole population, some 50 million people in England, 60 plus across the UK. We came to the digital party relatively early. We spent a significant amount of money, about £12 billion, or actually these days the exchange rate is rubbish, but about $18 billion. Which gave us a good infrastructure, but didn't fully digitize our records, and that's a pity. But we have a national spine connecting every point of provision of healthcare in order to ensure we can flow data securely between any points in the system. We have a full national data service to get records of what took place. So this isn't the health record, but this is the transactional record of the delivery of care in order to know how many people have had strokes, how many people have had heart attacks, the geographic spread of disease and so on. And that all pours through the national system. We have a national demographics service so we can appropriately join the records of our population. And we were early to digitize medicines, pathology, imaging, and referrals. Though interestingly, each of those systems now needs replacement, and that's our challenge, is how we do that in a standardized way that is interoperable with the same big system providers that we're all, except for NT, clever man, we're all ubiquitously using. We fully digitized our family and community practice, and they plow on. Though those records aren't structured as well as they might be, and that provides some challenges for us. But in our acute sector with our hospitals, that's more of a challenge. We've got some HIMSS level 7 hospitals using Epic and Cerner and doing very well from it, down to some hospitals that as Tim illustrated in Australia, are still using paper and the fax machine. We have banned the fax machine, and I've got a record on my desk of the last fax machine bought in the NHS, which was sadly this year, so we're going to have to go and hunt them down. We've allowed citizens access to their records. And for me, this is the fundamental. The reason for getting into this game was to reduce the knowledge asymmetry between the clinician and the citizen. And that empowered citizen has been so powerful in other industries for keeping the players honest. You've seen the revolution in financial technology. And every time Don and I get together, and I'm regretting the fact that COVID's inhibited it, we have a discussion about how much the US pays for insurance and how no one can see how the money flows in that system. We want citizens to help keep our health system at the peak of its game by having transparency. About 25% of the population now have access to their health records through apps and are using that to transact digitally. During coronavirus, and I know we'll come on to that in subsequent questions, but just to give you a hint, we moved to the overwhelming majority of all consultations being by telehealth or video consultation, and we managed to do that within a couple of months, which was an advantage of a national system, though that wasn't necessarily done in a completely free and fair way. It was just getting it done. Anyway, let's move to the next one.
Yeah, the spine, you have, and your colleagues have presented the infrastructure of the spine. Very, very impressive open source. Do you want to just say a word about that? I think this would be of great interest to our audience, how you guys put together the spine.
Well, the aim Exactly as Enti and Herco have discussed, this, health data is incredibly useful for direct care, incredibly useful for business intelligence. But in the wrong hands, you've now utterly ruined your trust. The need to keep it secure and safe was paramount here. So we built an infrastructure. I mean, literally laid our own fiber optic cables between every healthcare centre in the NHS, which was quite challenging, actually. I don't know if anyone's ever had to do wayleaves to get permission from a leaseholder to get a fiber optic cable into a bloody building, but don't. And to get access to that requires the healthcare provider to have been uniquely identified. So we literally asked our entire NHS population, healthcare provision population is about 1 million staff, to turn up with their passports. And we discovered a few people who weren't who they said they were, which was quite interesting. Some of whom had changed jobs several times, but always taken the paperwork on trust from the previous organization. And we've then got full security controls. It's fully encrypted. It was, when we put it in, fat cabling. We've had to redo it several times since to keep it up to speed. The aim is to ensure that all data between every service provider, including those pathology, those digital diagnostics, all our imaging, CT, etc., can flow freely, not just between sites within an organization, but between organizations, and critically to the way the NHS functions, between the general practitioner, the family physician, and the hospital sector that's usually providing most of that acute care and those pathology services. A copy of the fact that happened is kept centrally, and where we've got appropriate permissions, a copy of the clinical data is kept centrally. So just on that one for a moment, Don, we have a full national copy of everybody's family health record, but we can't see it unless the citizen and the GP have said okay. And so the way we transacted this, we said, look, can we have it centrally and anonymously? We want to know volumes and numbers and all the rest, but we can't drill into it unless you say okay for research or whatever else. And that currently seems to be working, and our population have agreed to that.
Interesting. We're with our health information exchanges very, very, very early on in looking at some of these encrypted split learning type of algorithms, where what you have is the data stays encrypted at the source, but then for, let's say, machine learning, part of the machine learning process can be done there at the source with the data, and then intermediate layers of encrypted machine learning data might get sent downstream for further analysis. This is really experimental, truth be told. A couple of the HIEs, in particular in Nebraska, are just doing some of the earliest experiments with that. But it's, I think, maybe a very interesting approach, even more broadly, to how we think about what you've just outlined. I think, obviously every country has its unique politics, to say the least. And maybe it would be interesting to go around and ask folks, in their country, what part of their country sort of, let's say, unique political environment or construct or sensibilities has maybe led to some unique challenges? So maybe Herco, if you can reflect on either something in the Netherlands, or maybe, since I know you've had to do a lot of crosswalking with the European Union, feel free to expand. In terms of managing a country's IT footprint in the context of the EU.
Yeah, sure. Well, politically speaking, or more culturally speaking, I think we have the GDPR, which is seen as sort of like the golden standard for privacy, and this also, of course, has many ties with exchanging health information. For us, this is still a very big and current issue, and we see this in the debates around the COVID exposure notification apps, for instance. We see this already, and this is due to two things. One is, that I already explained, is that there is no big government role in the doctor-patient relationship. So there is no basis to earn that trust on as a government. So as soon as we do something in that area, then it's immediately distrusted, which isn't quite strange. And the other thing is that this stems from the time that during the Second World War, where government records were instrumental in rounding up the Jews and other unwanted citizens, not just in the Netherlands, but everywhere in Europe. So we have actual experience of how records, government records, can be misused through political means. So we have a very healthy disrespect of government, which means I think it helps us focus on what's important for the patients, because this drives us not to look for the easy ways or the commercially most viable ways, but it drives us to do what's best for our citizens. But it does mean that we do have, sometimes we take 2 steps forward and have to take 1 step back again, because we're not allowed to take that step. And I think, like I said, this crisis is really showing us that once again, and we've learned this lesson, I think 6 or 7 times already. So it's really interesting to see how this will progress.
Yeah, I think one of the things we're finding in the United States as well is that COVID and the requirements to do telehealth, if you will, really put a huge burden on interoperability. And so it's not just interoperability of patient and the doctor, let's say at the time of the telehealth visit, but it's how to get the background information on the patient. How do you, once you've seen the patient, communicate not just a prescription, which, as Mario pointed out, can be done with SureScripts, or there are a couple of smaller vendors, but how do you bring that information from the telehealth experience back into the broader medical records? And we're working with our health information exchanges to do some of that, but there's still a lot of work to be done in really closing the various parts of that loop, and that these days becomes very clear when you want to provide care remotely, for sure. Mario, what have been some of the uniquely Canadian issues, if you will? I say that as somebody who was born in Montreal.
Yes, so as I mentioned before, we have these 14 different healthcare systems, and along with them come different colleges, different associations. So the view from different parts of the country are very local. So that's part of InfoWay. Part of what InfoWay tries to do is actually convene people, bring them together, and work towards these common standards and common approaches. And you were talking just a little while ago, talking about the integration of the virtual visits, the telehealth visit with the electronic medical record. And that's very much one of the things we're trying to convene the country around. So starting in March, I guess, there was this huge boom in online video conferencing, telephone use, and so on, which is largely disconnected from the record. So some of the doctors who may have electronic medical records were still making notes and then having to type them in and so on. So that's one of the big pushes we're trying to make right now, is to actually have proper integration of virtual visit technology, video technology with the electronic medical record. And as part of that, we're also trying to establish countrywide standards, or have countrywide standards adopted for the purposes of secure information exchange. We do not have a fancy spine the communications for us go over the internet, which is fine. We spend a lot of time making sure that those are secure, but we need to really establish those standards, and we want to separate the payload standards, be it HL7 fire with specific terminologies, from the actual transport standard, which could be any of the widely adopted internet standards. But it's very strong, and that's really what we try and overcome on a regular basis and try and bring people together. And because InfoAid does not deliver care, does not have a mandate to make rules or anything like that, we primarily try and influence people with good ideas and with sort of an approach that bubbles up their ideas as well, so everybody can buy into it together.
Yeah, no, that's a unique and I would imagine a challenging type of situation to do. Sort of thinking about the United States, I'm not sure how we would do that, but again, probably, we're sort of on our own journey as it for all the historic reasons that we know.
Yeah, so I'm just going to add, I think we're all on our own journeys. I think every country is definitely on its own journey, but there are a lot of similarities. And I think that's the value of the GDHP, which is sharing those similarities and try and reduce those differences, because we're all learning some of the same lessons and slightly different lessons, and the value in sharing is huge.
Yeah, for folks, great point, Mario. For folks, if you go to gdhp.org, so Global Digital Health Partnership, hence gdhp.org, you'll see some of the projects we've been working on, and you'll see some white papers on, for example, we did a international interoperability survey that gives you really a lot of details on the roughly 30 country members that are in the GDHP. This work has been led by Tim Kelsey. India with Dr. Lav Agarwal are the head of GDHP at the moment, have done great work, had an awesome GDHP conference in the last year to really move things along. You'll see some work streams there on the clinical consumer engagement, on thinking about evidence and evaluation, which is always an issue, I think, since in every country on some level. And then we're also doing some interesting work, and you'll see a paper on cybersecurity at that website that you can download that includes some things on the cybersecurity of devices, right? Because with this Internet of Things, it's not just the classic, PC terminal or mainframe with a database type of issues that we have, but cybersecurity issues have been distributed over all of the devices on the network. NT, you've, I guess, have the benefit of a small footprint, though extremely dense footprint. You highlighted earlier some of the differences between inpatient, outpatient. Maybe what are some of the other unique things in Hong Kong, especially given the multicultural nature of Hong Kong?
Maybe I'll just talk about, first of all, we're a public provider, which means the patients basically don't pay anything. Now, the paradoxical thing that I've seen is that the people have higher expectations of free care than they do of a lot of money in the private sector. They're much more forgiving of the private sector problems than they are of public sector, because they've invested in the payment, so they want to feel like they've made a good deal there. Where if it's free, they don't value it as much. So that's an interesting thing I've noticed. But they do have very high expectations of their free public health. Because it's probably going to be too well funded, so we have developed a very efficient system. Now, when I say efficient, you can read that to mean that it's under, since manpower is the most expensive thing, we have lower levels for the amount of care we deliver. So that has actually informed a lot of what we've done, is that our staff have to work.
I think we're seeing some latency issues with NT. Okay.
That's because Simon didn't lay that fiber.
Yeah. Yeah. Let me turn it over to Simon. Simon, the NHS has obviously been has had some sort of unique political visibility. I know in my few trips to England, really as part of GDHP, truth be told, there's always something in the English press about NHS. How do you sort of see your IT environment? How do you operate in that to do some of the amazing things you've done?
Well, it is always at the forefront of discussion. The NHS is as close as we get to a national religion. It's sort of universally worshipped, which is marvelous in one respect, but and universally trusted. It is the most trusted organisation in Britain and the most trusted brand in the country. The downside is that makes challenging some of what we do a little harder, as it's like attacking your mum. You just don't do it. The full state provision and the fact that all care, certainly all long-term condition care, is completely free for the individual citizen. And to put that in context, Don, as I'm sure you know, but UK Facebook fields are full of pictures of bills from US hospitals, just to remind people of how much we're going to enjoy our trade deal with the US, since we're blowing both of our feet off with Brexit. But it does lead to people expecting a full state funding of everything. So we're trying to develop a market here in digital health tools for the citizen, direct-to-consumer apps that help people navigate their health record, that help them improve their understanding of their health, that help them improve their long-term understanding. And we're having real challenges in working out a funding model for that that works for the consumer, given that there's a reluctance for the consumer themselves to pay. And we're literally talking about, $2 per citizen per year type levels that people are reluctant to pay because health is free. We do have tremendous advantages with the NHS that we can think long term. We have to move past the political cycle. Believe me, during coronavirus, we thought very short term indeed, and we're able to move nationally, which was an advantage. But we've been running an incentivization scheme for family doctors now for about 6 years around public health initiatives, reducing the nation's blood pressure, cholesterol, body mass index, and so on. And it's one of the largest incentivization schemes for outcome in healthcare run in the world, and has been really quite successful at a national level. It does alternatively mean that there isn't an 80-year-old in Britain who isn't taking a statin, an antihypertensive, and a variety of other medications on a sort of daily basis. They all rattle slightly when you bring them into the ED. But we have reduced our cardiovascular risk rate quite markedly. So we have huge advantages in trust and scale and scope. We have disadvantages in that challenging the way things are done in order to improve them can sometimes be quite sticky.
Let me ask an interoperability technical question, and well, each of folks, a version maybe for their country, but in the UK, if I were an app developer, what would I hook up to get the patient's medical data? Assuming the patient gave permission, would it be the spine, or how, if I were an app developer in the UK, what would be the endpoint I would need to discover to get patients medical information for an app of their choosing?
So at the moment, you essentially you couldn't hook up to the spine, and I'm very much with Mario's comment that we need to move to an internet-first environment, and we're looking at the cost of moving to an internet. We were based on the model that seemed appropriate at that time, but the hookup would be to the primary care record, and indeed we've now rolled nationally a thing called GP Connect, which standardizes the APIs to plug into that family health record, and that's two-way, by the way. So that's both read capability and write capability in a standardized structured format into primary care records. And that's being widely utilized. The other is app developers who are looking, and this may be true elsewhere, I'd be interested, in very specific and niche products. So we've seen a lot of mental health apps to support people through depression, through cognitive behavioral therapy and so on, some of which are getting really very impressive results. And what we want is the output of those to flow directly into people's mental health records. And again, with relevant permissions, that can now happen.
Awesome. But NT, are you back on?
Yeah, sorry about that. I seem to have got kicked out.
No problem. Is it possible to, let's say, hook up a app of a patient's choosing to the hospital authority backbone, or how do you guys sort of see that app economy playing out in Hong Kong?
So what we've done initially is not with the hospital authority system so much, but with the government EHR system, where we're allowing third-party systems to connect up with that infrastructure, and they can. Well, they can contribute and they get access to record, but that's more of a medical record type of application. So in terms of more like a modern app economy thing, that's something we haven't got yet, but I think it's clearly something we need to be going in. We're talking about engaging with the sort of the health innovation ecosystem a lot more, but we're still quite early in this whole thing. So I think it's something we need to be building out, and I definitely would be looking to see what Simon's done in England, and we can learn a lot more from what everybody else has done in that area.
Great, thanks. Mario, how do you see the app economy and apps playing out in the Canadian health system, and maybe specifically with some of the work at InfoWay?
So right now, third-party apps really can connect to sources of data. So patients can typically use a hospital extended portal, or the electronic medical record of a physician may have a web component to it. One of the things that we are working towards is actually create an API-based ecosystem where we wouldn't necessarily centralize the data, but would have the ability of having certified applications connect to the API gateway and then fetch information to feed these apps. We don't necessarily want to build a massive infrastructure to hold all of the data, although many of the provinces have large EHR repositories. And the first element of working towards that is actually identity management, because you need to know who is connecting to what. And related to that identity management comes identity proofing. How do you actually know that they are who they say they are? And of course, again, related to that is consent. Is there consent both on the provider side and the patient side for a particular app to access some piece of information? So we're still behind, but working furiously to get at least a lab environment in place where we can actually really test out some of these ideas and processes.
Yeah, it's interesting. We obviously have a number of issues with identity management. There's a push in parts of Congress on a patient identifier. One of the interesting things to my mind is how the authentication in the private sector, at least in the United States, but I'm guessing globally, has moved fairly rapidly. I mean, any bank or folks who are extending credit cards, loans, or activities have extraordinarily rich under the covers, behind the scenes authentication tools. So it will be interesting if those private sector tools, how we might use those, especially for the situation such as Canada or the United States, where maybe we don't as much, infrastructure in that area as before. Let me turn over to Herco. Herco, how do you see apps in the Netherlands? Is that, and the ability of apps to get information? I know you outlined the app you guys are building. How do you see that playing out?
We're similar to what Canada has already told, what Mario said, that we don't have a big infrastructure where you can just have one endpoint and connect to all this data. There's so many endpoints that we decided to go for an API strategy based on HL7 CDA and FHIR profiles that are very similar to other profiles used internationally. So what we have is apps that need to be certified on their security. They need to be ISO 27000 and the healthcare version of that certified, and they need to have a governance in place for what if something goes wrong, and how do you port your data to another app if you want to switch apps and still keep the data that you have. So there's all those kinds of issues that are being dealt with within the MedMay trust framework, including not just technical standards and APIs, but also more structural. How do you structure the data? How do you structure the semantics of the data? So the patient can actually understand, not just, they don't just get the data, but they get the understanding as well. Because one of the things that this enables us, if we have SNOMED on the clinical side or on the provider side, we can use patient-friendly terms in those apps without much effort, because we also have a thesaurus with patient-friendly terms based on magazines, news, all kinds of sources that we use. So there is that. One of the things that we do work on with, for instance, the people from Orca, who Simon probably know, is that not all apps promise are true, and they deliver on their promises. So one of the things that we're doing is that when they're certified, we have a program that traces that traces the research that's being done on whether or not they are actually bringing health gains or not. If they, everyone wants an app, but we want those apps to actually improve the health. So we want to have good outcomes, and we need to measure those. And just having downloaded and used an app isn't enough. That's just the means to the end, and we need to keep our focus on the end as well.
Great. Looking at some of the questions, some of them are, I think we've answered in parts. One sort of modern technology, or two sort of modern technology questions come up. They're not strictly related, and both of them have large buzzword components to them. So I'm going to apologize for the buzzwordness of it. That's not a word, I'm sure, that concoction. But maybe either, any thoughts from folks on, we'll ask about both blockchain and the cloud. Again, monster buzzwords. But one of the things that's sort of interesting in the general concept of blockchain is the concept of sort of a self-sovereign identity, which might be part of a modern patient identification and a new model of patient control. And also, would blockchain serve as a good consent mechanism, as we move forward? I think in some countries, the consent is part of the social contract. I think in others, like the United States, consent is not part of the social contract. I don't know if folks have thoughts on sort of the combination of modern ways of looking at consent, the sort of the cryptography of blockchain to secure that. Any thoughts there?
There's some work going on in Canada in terms of blockchain. Right now, there isn't an official self-sovereign identity sort of production system, but there's a fair amount of work, particularly in some of the large teaching hospitals that's looking at it. In British Columbia, there's actually a fair amount of work that's looking at using blockchain to publish provider credentials. So people can actually verify whether a provider is still licensed to perform certain things, whether they're licensed to prescribe, and so on. You're right, it's a big buzzword, and then there's all sorts of things that are supposedly happening around it. We haven't yet seen any big production system using blockchain yet. It's a fair amount of exploration. In terms of cloud, as I mentioned, we're building this sort of innovation platform lab, and we're doing so in the cloud. We're also doing it with sort of the latest trends in terms of serverless. For a number of reasons, we try and keep the components really small so we can update small components on an ongoing basis, and from a cost perspective as well. So you don't have things like virtual machines running that are not doing any work. So you only pay for the actual invocation. And we think that the cloud is the way to go. In Canada, we have both privacy legislation, privacy rules, but also expectations that the data remain in Canada. And it wasn't until the last couple of years that all three major cloud providers from the States built infrastructure here in Canada. And even now, they don't have all of their products deployed in Canada, but it is allowing a significant move to the cloud. And we're seeing that both on the government side, on the private side, a lot of people getting rid of their data centers and moving to these cloud platforms.
Interesting. Yeah. I believe, I know that Microsoft has a FHIR, so the Fast Healthcare Interoperability Resource server up and running on their Azure platform. And I'm told that Google and Amazon are working on FHIR, cloud-based FHIR servers. Other thoughts on how over time that type of technology might be of use?
So Don, from where I sit, I think the word you want is buzziness. So
okay, thank you. Thank you.
Blockchain
here who are really better speakers of English than I am. So much appreciated.
So blockchain and from where I sit, blockchain and cloud are on two opposite ends of the buzziness spectrum. So blockchain, I mean, we've looked at it, and because it was so buzzworthy, but I think very much like Mario, we have not seen a solid use case that warrants us, actually investing in it yet. I mean, it may be we don't have those particular use cases. Maybe in a more distributed system like you have, it might be more useful. So it's on our radar, but nothing we're actually exploring actively at the moment. The cloud is totally different. The cloud is something that is very much something we're moving on now. Just because of the issues about privacy and accountability of data custodianship, we are actually taking cloud technologies and building our own private cloud as the primary cloud. Now, the public cloud we're also exploring, but it'd be different use cases for sure. So I think the technologies that and the benefits of cloud you can get even if you by building your own cloud if you're not happy to go to the public cloud. And we're big enough that it's justified, I think. But certainly the tech is the way to go, no question about it.
Okay, good. Very good. Other thoughts there? Let me, so we all obviously have our day-to-day issues in terms of our countries and what we're trying to accomplish. their policies or products, as the case may be. I'm curious in terms of sort of motivations for the future. I think, like a number of folks, went into this entire field because I thought healthcare desperately needed automation. When I was a resident, I was trying to convince my faculty to use modern technologies like the alphabet for results, as opposed to just reading results as they came in for, let's say, microbiology cultures. I pointed out, I remember to the head of medicine at the University of California, San Diego, that this was 1984, that the alphabet was a proven technology and that we were ready for it at UCSD. This was pre-computerization, obviously. I'm, at least, and maybe this is a US phenomenon, but I think it's global. I've been stunned at how little automation we've actually put into healthcare. In this era now with Internet of Things, with sensors, with connected devices, I'm curious if, for folks' thoughts on how do we get healthcare from this very labor intensive, certainly in the US, documentation intensive. What do you see as, for each of you as the opportunities for automation? NT, maybe we'll start with you in terms of what you sort of see, let's say over the next 10 years, not tomorrow, but over the next 10 years, how do you see your system evolving in support for just automation and that business intelligence that, you discussed earlier?
Yeah. So I think one of the key issues that we're facing is the lack of medical manpower. That it's impossible for us to grow our medical manpower quickly enough to meet the demands. And it's not just population growth; it's aging population, and it's higher expectations of people. So just if you don't have enough people, you can't work the old way. So they're more comfortable, of course, with how they grew up and how, in terms of their clinical mindset. And this is how we used to do things, and they're comfortable. But I think more and more people are realizing that you can't keep on doing that because you don't have enough people to do the job you need in that old mindset. And so what we're seeing now is certainly a much bigger acceptance that if we're doing a new, rolling out a new service or planning a new service model, there's going to be a digital component. And people are now, putting that in at the beginning rather than something they're going to tack on at the end. So I think that's something we're seeing, a big shift in the mindset of the clinical population. I think another one will be patients themselves. As we engage patients better and they become, a real partner in their own care, and they're doing it through digital interaction. And we'll see that, again, you're not going to be able to have a clinician hand holding the patient, throughout the day. So there's going to have to be automation back there in how we interact with the patients or how the patient interacts with us. I think the third thing is in terms of decision support. So what we're building, this is a lot of what we're building at our AI work to do is to build lots of little, AI or maybe rules-based systems that are just running constantly in the background and picking up things, providing a digital safety net for now this is mostly in terms of the clinical decision making, and they're making sure that the protocols are being followed. We didn't make some big mistake. We didn't miss some important thing. And that's just a bunch of these little, computerized things running in the background, little demons, which will be, finding these problems and then surfacing up to the clinicians in the appropriate way during in their workflow. So those are three areas I think where it's basically impossible without automation.
Okay, great. Herker, you were shaking your head about automation.
I agree with I agree with what NT said. For the Netherlands, workforce is also a very big issue. We don't have the people or are able to get the people that provide the care that needs to be provided. So there needs to be other solutions, and automation is a big part of that. One of the things that I'd like to add, though, to NT's points is that one of the things that this crisis really has shown us is that there is a big portion of care that wasn't really necessary, that was still in the books and still being performed. And so there is some, let's call it just some hot air that's being released out of the system. That is now a big part of the discussion of, do we need to restart those, and why would we restart those types of care? So I don't think automation is the only answer. I think there's some smarter care and not just more digital, or where we can organize it better and maybe to focus more on prevention, and data will play a very big role in that. So I do think that for the next 10 years, it will be more of a balance between, is this care really necessary? Do we need to wait until it needs to be repaired, or can we invest more in the prevention of these episodes?
Yeah, it's interesting, the whole, I mean, digital can clearly bring transparency on scale. And I think that's going to be transformed. But I know in the US, I've encouraged some of the folks doing research to think about doing research on, a digital scale using things like log files and, more modern approaches that really use the continuous sensing we have, rather than, for example, in the safety field, trying to find outliers and errors, and actually look at reduction of central variance. Mario, how do you see automation potentially playing out in Canada?
Well, how I see it playing out and how I would like to see it playing out is probably a little bit different. But the way I would like to see it play out is very much along the lines that NT described, where people have used the term real-time health system and so on, but it's really an event-driven system where an event happened, be it an encounter, a prescription, a test, those events are published, and there's monitoring that happens and workflows that kick off based on established protocols. I think that would help with the manpower or person power shortages, and it would just help with the prevention and so on. So to me, that's the key to the future, so that you have this event-driven system. Will it happen? Maybe. I don't know. We'll try and push hard for it.
Awesome. Simon, maybe for the last answer here.
But just quickly, so clinicians have always been rather against automation, arguing that medicine is an art best performed as a one-to-one interaction that's deeply unique to the discussion with that patient, much of which is not quite as special as we sometimes like to make out. But combine automation with some of the best artificial intelligence / machine learning, and we can begin to provide a service that is effectively automated, checking results, for example, with a degree of personalization to a unit that is as close to one as makes no difference. So at the moment, we have people going through or looking at reams of renal results, estimated GFR and creatinine results, in order to spot deterioration. And they're looking for the little red asterisks in the corner, or the little pop-up that says this person's now outside the normal range. This is, I mustn't swear. Americans don't do swearing, so I won't. But it's no good. What we need to be looking for is whether that has still within the normal range, but has significantly deteriorated within a short period of time, and is an indicator for AKI. As you know, Stream's product developed by Google Health did a lot of effort into this. And in the UK, in one of our hospitals, UCH, has significantly prevented ITU admission as a consequence of simply spotting a deterioration in CK and alerting the clinician to that. We need to have that degree of automation, just as completely boring standard. Chest x-rays need to be read by machine first, every time. Interestingly, mammograms, in order to determine the genuine 3D size of a lesion on that, AI is better than the human being. So can we just take the things where it works and get on with it, with a degree of personalization that then allows us, the warm clinicians, to do all those interesting edge cases that the machine can't do and really enjoy the art of medicine alongside the machine doing the science.
Well, that was very, very well stated about our digital future. Let me thank each and every one of you. I think I hope for the audience getting this truly global perspective from leaders in making healthcare digital. The group of folks on this panel have really been great leaders in the GDHP and getting all of the countries together to a higher level of, let's call it digital maturity. That's a goofy term, but it does have an element of truth to it. So let me thank each of you for participating. I know for some of you, the time zones and hours were quite challenging, but greatly appreciate this. And we will turn it over to Avinash and our media team right now. Thank you.
Thank you very much.